Hi, everyone. Thank you very much for attending this presentation today. My name is Ali Kamisipur, and I'll be presenting on behalf of my team, Dr. Andre Suarez and Dr. Joanna M. Davis. The topic of today's talk is a comparison of recommendations for computer-based decision system and tobacco treatment specialists, insights and lessons learned. Smoking remains to be the #1 cause of preventable death worldwide. While 70% of smokers visit some sort of a healthcare provider at least a year, and evidence-based tobacco cessation treatments have been a proven way to aid tobacco users to quit. Unfortunately, clinicians continue to report limited cessation activities due to either the lack of time or proper training. And these factors basically were the components that triggered our research interest in this area. The components of the rule-based system that we work with consist of the patient data, the computer rules, and the rule engine. The patient data was basically data collected in a dental clinic in the Midwest, and our team did not have any involvement in collecting that data. We were handed a CSV file of de-identified data patients, and we basically work with that data. We derived our computer rules from the 2008 guideline of treating tobacco use and dependence. And these two components were fed to our rule-based engine and basically produced 3 personalized reports. The first report was the treatments report, which consisted of all the medications and dosages and the therapies that were recommended for this specific patient. The second report was the discussion points. This report consisted of all the decision factors, the warnings, and the explanations for this patient. The third report was the patient's facts. This report included all the patient information, tobacco history, medical history, and health conditions related to this patient. Now, the goal of this analysis was to provide a chart data very similar to the chart data that a doctor basically reviews prior to meeting with a patient. And the value that this would provide for a healthcare provider is that a healthcare provider can basically have an evidence-based, tailored cessation recommendation in fractions of seconds. What we see in this slide is the preliminary recommendations for one of the de-identified cases in our study. All of the headers here represent the set of treatments that have been recommended by the 2008 guideline. And this is all of the possible treatments that could have been chosen. The rows here represent all of the recommendation systems that have been used in our study. The first 2 rows represent the 2 versions of our rule-based system. The first version was consisted of 29 rules derived from the 2008 guideline. The second version was an enhanced version of the first version of our rule-based system. The following 4 rows, TTS 1 through 4, are the tobacco treating specialists that assisted us in conducting this research. All the X marks here represent that the this specific recommendation system has recommended the use of this treatment for that patient. As you can see, all of the recommendations here agree that the use of motivational interviewing is beneficial for this patient. However, they do not all agree on all of the treatments that need to be used for this patient. So, for example, TTS1 recommended the use of the motivational interviewing, 2 milligram nicotine gum and nicotine lozenge, followed by 14 milligram nicotine patch, a CBT, and referral to the quit line. Other TTSs did not agree with completely agree with this recommendation. Now, this was one of the limitations to our study, that each of basically for the TTSs to analyze each of these cases would take something between 1 to 2 hours. which basically limited, and due to the fact that the TTSs were voluntarily assisting us with this research, this basically was a limitation for our study. And at this point, due to the disagreement between the TTSs, we thought of quantifying the level of agreement among the recommendation systems. And so here in this slide, what we are seeing is the reliability agreement that has been calculated among the recommendation systems. The graph on the left represents all the reliability agreements calculated among the TTSs, while the graph on the right represents all the reliability agreements calculated among the TTSs and the second version of our rule-based system. We have calculated two values here in these graphs. The first value is the Krependorf's alpha, and the second value is the Cohen's kappa. The Krependorf's alpha has been calculated to represent the inter-rater reliability agreement among all the TTSs. The Cohen's kappa coefficient has been calculated to represent the inter-rater reliability agreement between pairs of TTSs and is represented with bars. Now in this graph, the x-axis represents the 10 cases that have been used in our study, while the y-axis represents the inter-rater reliability agreement value. For the Krependorf's alpha, or the reliability agreement among all the TTSs, any value below 0.667 is considered as low agreement. For the Cohen's kappa coefficient, any value between 0.8 and 1 is considered very high levels of agreement. Between 0.6 and 0.8 is good levels of agreement. Between 0.4 and 0.6 is acceptable, and anything below 0.4 is either low or very low levels of agreement. As you can see here, the level of agreement among the overall level of agreement among the TTSs is low, 0.20, and is 0.294. The pair TTS1 and TTS3 have the most level of agreement with a mean of 0.433, followed by the pair TTS1 and TTS4 with a mean of 0.432. TTS3 and TTS4 were the only pair that represented very high level of agreement in certain cases. 2 and 7 represented here with the pink bars. The next thing we calculated was the correlation between the recommendations made by the TTSs. And there were two facts that actually stood out here. The first being the fact that there were certain treatments that had very high level of correlation with each other. For example, 2 milligram nicotine gum and 2 milligram nicotine lozenge showed a very high level of correlation. And the reason for that is due to the fact that these treatments could be used interchangeably. The second fact that stood out here was that there were certain treatments that showed very high level of correlation, but with a negative sign. For example, readiness to quit and motivational interviewing is a good example of that. And the reason for this is, consider the case that a patient wants to quit smoking. All of the TTSs basically agreed that in this case, there is no need to pursue with the motivational interviewing, and they would straightly jump into providing a treatment plan for this patient. On the other hand, if a patient was not ready to quit, all of the TTSs agreed that it would be beneficial for the patient to provide a motivational interviewing prior to getting into any treatment plans. The next thing we calculated was the percentage of treatments that were used per group by each of the TTSs and the RBSs. As you can see, the 4 milligram nicotine lozenge was the mostly used treatment here with a percentage of 62.5, followed by a 4 milligram nicotine lozenge with a percentage of 47.5, and a 21 milligram nicotine patch with bupropion with 40% recommendations. The referral to the quit line, and as expected, was the most used treatment option at 95%, followed by the CBT at 92.5%. However, the CBT, the referral to the quit line was not selected by, for example, TTS3, and the justification for that was that the specialist mentioned that the patient needs one-on-one in-person tobacco counseling. The specialist highlighted mental health, seizure risks, and psychiasis as decision factors. The discussions and lessons learned, number one, is that both versions of the rule-based system recommendations relied solely on the information from the 2008 guideline, while the recommendations from the TTSs were based on the guideline and beyond, including their clinical experience, training, and recent treatment information. The second fact was the disagreement among specialists, which came up as a surprise for us, but some providers would say that this was actually expected because the guideline is just a guide and providers can factor in experience. And this is why evidence-based practice allows consideration of best evidence, professional experience, and patient preference. The guideline recommendations could be classified regarding the level of confidence that the treatment fits the patient needs and contraindication levels for each suggested medication, as proposed by Mitchell et al. In 2005. We had to make decisions with incomplete and imprecise data, and the differences in treatment recommendations between the rule-based system, the individual TTS, and among all TTS demonstrates the need to further refine treatment rules so that they accurately reflect not only the 2008 guideline, but current treatment protocols and patient differences. In the end, I would like to thank you for your attention, and we would like to acknowledge the College of Applied Science and Arts at Southern Illinois University and the Data Science to Patient Value Initiative at the University of Colorado Anschutz Medical Campus for supporting our research. Please feel free to contact us with any questions and concerns. Thank you very much.